presenter is Dr. Rich King, the medical director for PHI Air Medical in California and Texas. Studied at UC Davis. Give us a little bit. It's also a SWAT doc for Reading PD. And some of you know that Dr. Rudnick and I are also trained up in tactical medicine. It's, you know, if you haven't done it, great. Take a couple weeks, take a vacation, do SWAT EMS, or tactical EMS training. You won't forget it. Anyway, and he looks just like this fellow right here. So with that, Dr. King.
Morning. Can you hear me okay? Yeah, in the back? Good. All right. Just to get started, I want to know exactly who I'm talking to. How many first responders? EMTs. Whoa. EMT paramedics. Flight nurses. One. Great. Okay. And one in the back. So this talk I developed to be relevant to all levels of pre-hospital professionals. If I'm speaking about something that's outside your scope, it's still relevant because you need to understand what's going on with the person you're working with that it is relevant to or within their scope, so that you can predict and anticipate what their needs might be so you can more efficiently provide care for patients. Stop me anytime, questions, whatever you need. So, define our objectives. We're going to review airway anatomy, go over the goals of airway management, tools of the trade, what are we using to establish or maintain an airway. We're going to develop a systematic approach to airway management. We don't want to be chaotic, we want to do it the same way every time so it becomes a habit and gets done right every time. We're going to discuss some special considerations in the management of airways with burn patients. So, I already got a little bit of an introduction. I started out in EMS. I was an EMT in 1991, became a paramedic in 1993. Worked as a medic until I went to medical school. Right now, I'm board certified in emergency medicine and critical care. Spend most of my time in the intensive care unit at Nursing Medical Center. And right now, I'm a medical director for PHI Air Medical, and as mentioned, I'm a SWAT physician for the Reading Police Department. So a little history. Where have we come from? In 1970, President Reagan signed an act and legislation that allowed firefighters to go out into the public with a physician, usually a cardiac care physician, to go pick up emergency patients, specifically heart attack patients. They wanted to bring the hospital to them to start treatment sooner. We all know how that's evolved. Now we have stemming alerts and everything that is about time and muscle. That's where we came. That's where we came from. In that period of time, though, what they did was they trained these firefighters to do procedures to free up the hands of the physician or the team that was going out. And these procedures were novel at that time. So what's the difference between a technician and a professional? Right now, an EMT is emergency medical technician, which I think is a vestige. It's something that's historically relevant, but I don't think it's true anymore. Technician is someone we can train to do a procedure, but a professional is somebody that applies critical thinking and applies those procedures in a method and a way to affect the means to an end. And you remember Johnny and Roy, you know, they'd call up Dr. Brackett and they'd say, this is what we got. What happened was eventually the physicians realized that these firefighters no longer needed them to go out with them. They could actually trust their ability to do an assessment, get a history, do a physical exam, and relay that information to the doctor still at the hospital. And that's kind of where we picked up with Johnny and Roy. Now we're much, much different. You guys are professionals. You guys are doing your histories, you're doing your physicals, you're applying critical thinking skills, and you're acting on protocols and utilizing your critical thinking skills. That makes you professionals. And it's a little bit of a soapbox for me, because I don't think of you guys, even though it says technician on your patch, you guys are emergency medical professionals, not intubating monkeys. We can train a monkey to intubate, but it's much harder to train him to know when to intubate and when not to. This is a professional. Who knows who this is? Right? Chelsea Sullenberger landed the commercial U.S. Airways plane on the Hudson River. If you've never YouTubed his comms with air traffic control, and listen to how precise and how thoughtful he is during this very chaotic emergency situation. This guy is calm, cool, collected, but he had actually done emergency landings like this for 20 years in practice, and that's what we practice. It's practice, practice, practice. It's simulations. It's why we do simulations. He may not have had these exact same variables, but he knew the system. He was systematic in his approach of what his options were and how he was going to safely land that plane. So you'll notice I titled this talk, Airway Management for Pre-Hospital Professionals, not the technicians. You guys are all professionals. It's because you're applying critical thinking to achieve the end, which is just to help our patients, right? So, airway management goals. We want to achieve or maintain an open airway. We want to achieve or maintain adequate oxygenation. And we want to make sure that we can maintain and allow our patients to ventilate. Okay? So, what happens if we fail? What if we don't do our job, if we can't achieve our goals? If we fail to open the airway, we don't oxygenate, we don't ventilate. If we don't oxygenate, our oxygen levels go down, the oxygen content goes down, we can no longer perfuse our end organs, and we have organ failure. If we don't ventilate, CO2 rises, pH drops, and now our enzymes in our end organs don't work, we have organ failure again. There's an acronym called HOP. It's very easy to remember: hemodynamic collapse, low oxygen, and low pH. Those three things will kill our patients. We need to do everything we can to avoid hemodynamic collapse, low oxygen, and low pH. So, airway anatomy. This is out of Netter textbook. You can see here, if I can work this, tongue, oral pharynx to the soft palate on the back, nasal pharynx above it, posterior pharynx, vallecula. The vallecula ties right into the supraglottic area. This is our larynx, trachea, with the esophagus just below. Okay. You can see it's not too hard for these soft tissues to fall flat if we don't have muscular tone of the tongue and the cardiopharyngeal muscles that hold the throat open, if someone's unconscious or just fills with blood. So we have to be aware and cognizant of how these anatomic structures relate to each other so that we can either open it or put a tube in it to achieve our goals. So, an example of what we were just describing. This is an open airway, oral pharynx. The tongue has tone, it's up. We have a nice passageway right up into the trachea, which is anterior to the esophagus. This is bad. This is snoring. This is somebody with a brain injury that has no muscular tone. So, we can't see through a patient. We can't see this. So what are the signs? What are the causes, options? So how would we know that our patient's got an obstructed airway? Anybody? Right, no chest movement. What else? So snoring respirations, loud breathing, or no sounds at all, which goes with no movement of the chest, right? So who here is familiar with mixed martial arts or jiu-jitsu or any of those techniques? There you go, one in the back. So anybody that's watched mixed martial art fights knows that most of the fight, with the exception of the early knockout, is the two fighters, they're struggling for position. Because you got to get position before you can submit your patient. And that's exactly what we're doing. We're struggling with our patients. We're fighting against badness to maintain their airway. We have to get a good position before we can get them to submit to getting air in, air out, and ventilating. So, right here we have a patient that has what we call a bump or a riser under their head. An ideal sniffing position. We're familiar with that term, but what does sniffing position mean? Usually if I ask, some people say, well, it's kind of when your nose is pointing towards the ceiling. Well, there's more to that. What we want to do is we want to extend the head up. We want to make sure the ear is at the level of the chest. What that's going to do is it's going to make this corner that we're trying to go around as straight as possible. Okay? We're going to flex the neck so that the face is parallel with the ceiling, but we're going to lift the head so that the ear is at the level of the chest. That's a key take-home point. You can identify whether or not, when you walk up on a patient, if their airway is going to be optimally positioned so that it can maintain an open, safe passage for air movement. This is an MRI of the same deal. So here, there's no pillow behind this patient's head. You can see here, black is air. So this is the trachea, this is the molecula, posterior pharynx, and what's this? This is all a bunch of soft tissue. This is tongue, this is the soft tissues of the soft palate, and it's all collapsing on the airway. Now all they've done in the same patient, all they did was put a pillow behind it. Now look, clear saline. Make sense? Again, same picture, same MRI. Now this patient, instead of just lifting the head, they didn't lift the head, there's no pillow here. But what they did was they hyperflexed the neck. Now you can get too aggressive, and I've seen people do what's called, or even been trained to do what's called the bowling ball. And what you can do is, this is open, that looks great, but look what happened. By overflexing, now you pinched off the area just at the larynx. So this is not clear saline. This is not open. So you need to minimally flex the neck. Is this parallel with the ceiling? No. Is this? Yes. So if you're parallel with the ceiling, you lift the head so the ear is at the level of the chest, you're going to get a nice open airway. So, no bone. This is just more examples of the point I'm trying to make here. Here's a neutral patient. You can see, look at that angle that we have to overcome to get a straight shot. If you're going to put a king LT in, if you're going to intubate the patient, you got to go around a corner and up again, and then down again to get to that area. This patient has head extension, but no lift. This patient has proper sniffing position with a lift. You can see that this angle now has flattened out. The difference between here and here, you can overcome that with a laryngoscope or a tongue blade, an OPA. You can push all this soft tissue forward and make this very, very straight. Make sense? Okay. This is a difficult airway. This lady is morbidly obese, getting ready for surgery. Now, we've got the ear here, got her chest somewhere up here. Her airway's going straight back, and we know that the trachea dives forward. So we're going down and up. That's almost, you gotta look around the corner. It's very, very difficult. But if we stick to our principles, if we're methodical about how we approach these patients, how can we optimize her position so that we can get her to submit to our treatment? We want to put her ear up the sternal notch. So we ramp these patients. You may need multiple towels, pillows, whatever you have to do to get this ear up to the sternal notch, up to the top of her chest. And look, now she's got neck flexion. So her face is parallel to the ceiling. We know now that her airway is at least optimally positioned to give us the best chance for success. It's called ramping. So same lady, look at the difference. Now, you might say that takes a lot of time. What if they're in distress? It's going to take a lot more time if you're fighting going around a hard corner than to invest the time up front and optimize your chance so that you're successful as soon as possible. Invest the time. Don't be the monkey. Don't go straight for the tube. Be the guy that's thoughtful and methodical and get success. Bad picture. I just spent 5 or 6 slides on putting people on their back and sniffing position. Who here would put this guy in a sniffing position? Thank you. So again, we're critical thinkers. This guy is awake. He did survive. He was awake during this picture. He's maintaining his airway. In fact, you can see his airway. It's right there. Right? So we have to be able to think, what is our goal? Have we achieved, are we maintaining an airway? Yes. Does it look bad? Yes. Could we do something to make it worse? Yeah, put him in the sniffing position. Right? So if we've achieved our goals already, we don't have to do anything. Just get him to the hospital. Right? So we want to be methodical in assessing the situation that we're in. We want to assess and be able to predict how difficult is this airway going to be if we choose to move forward and manipulate something. So we go through what's called LEMONS. It's an acronym for an airway assessment. It's very quick and easy to do. First, we're just going to look at the airway. We're going to evaluate it. We're going to assign a Malin score, which I'm going to go over here in just a minute. We're going to look for any obstructions that might get in the way from for us doing what we just talked about and positioning our patients optimally. We talked about flexing the neck. Well, what if their neck can't flex? Then what are we going to do? Is it going to change how we approach the patient? Then we want to understand how we can predict who may or may not desaturate quickly during our attempts to maintain their airway or achieve their airway. So we're going to look. So these three patients have three different airways that we can assess visually as soon as we walk in the door. The girl on the left has what's called micronathia. She has almost no chin. Look how small her mouth is. It's only 2 teeth wide. What are the likelihood that we're going to get an OPA in her, if we're going to get a king LT in her, or a laryngoscope if we're going to try and intubate? She's going to be very, very difficult to airway. If she's oxygenating, she's moving air, we may not want to do anything, and maybe we just want to drive faster. Ideally, this is an OR intubation, an awake fiber optic intubation with an anesthesiologist. Don't force a bad situation. If you can predict something, if you have minimally achieved your goals, and you can predict that doing something more is going to be challenging and may actually cause harm, drive faster, but safe. This girl right here with the stick in her neck, what are the odds that we're going to put her in the sniffing position? What are the odds that maybe her anatomy isn't quite symmetric? She's going to be very difficult to control her. Again, in an ideal situation, she's an OR intubation. Now, if she's not breathing, she's apneic, she's in cardiopulmonary arrest, we do the best we can, because you're not going to make her worse at that point. But if she's got an airway, she's oxygenating, she's meeting minimal requirements, don't force a bad situation. And this one on the right, a little bit more subtle. It's kind of a bruise over the neck, but if you look carefully, the landmarks, the Adam's apple, the larynx that's usually present on a man, it's gone. There's probably a lot of underlying soft tissue swelling there that once we get in, again, the anatomy can be distorted. There can be a large hematoma, there can be a laryngeal fracture. So just look, try and predict, is this going to be smooth sailing? Am I going to be able to predict what I'm going to run into if I make the next step in getting the airway? So we're going to evaluate. This is a typo. Oh, actually, they fixed it, so it's 332, good. So any patient that can take their own 3 fingers vertically and put it in their mouth means that they're going to have a mouth wide enough and able to open up well enough to accept a king LT, an LMA, a laryngoscope blade, a fiber optic blade. You're going to be able to assess the back of their throat. If you can fit 3 fingers from the tip of your chin to your larynx, you're going to be predicted to have enough of an angle. Remember those S-shaped angles we're trying to go around the turn? If you have something shorter than that, it makes the angles more acute and harder to get around. But if you have 3 fingers worth, you're going to be able to, if we are able to position our patients, we're going to be able to flatten out those angles much easier. And then the last 2 is the bottom of the back of the chin to the larynx. Again, if you have these dimensions, you can predictably anticipate that the anatomy is what you want it to be so that our positioning will work. Anything less than that, you have to say, well, this may be more difficult than if it was normal. Here's that Malin-Potty score. Top left is a perfect Malin-Potty. This is what you want all your patients to be. Unfortunately, they're not. If you have them just open up their mouth, you take a look in. If you can see their tonsils, their uvula, and the back of their throat, it's Malin-Potty 1. That's predictably a very normal, easy airway. Malin-Potty 2 is the top right. You can still see the top of the uvula, you can still see the top of the tonsils, but you can't see the back of the throat. You can't see where they go to the bottom. Malin-Potty 2. Not terrible, but not perfect. Malin-Potty 3 and Malin-Potty 4 should give you pause before you start doing anything advanced. Especially if you're going to think about sedating or paralyzing a patient, or if the flight nurse that you're taking your scene call to is thinking, oh, we should just go ahead and RSI. Look at your airway first. If you can't see the uvula, if you can't see the tonsils in the back of the throat, predictably the view you're going to get when you start looking for that epiglottis, predictably will be difficult. And a Malin-Potty 4 is even more so. This is typically what you can expect to see correlating with those Malin-Potty scores. Said Malin-Potty 1 is smooth sailing. You can see the epiglottis, vocal cords, originalis. Again, here you have the epiglottis, but you can't see the cords. epiglottis, back of the throat, and here's just a bunch of soft tissue. Who knows where those landmarks are? Very difficult airway. If you have a Malampati 4, you can basically count on getting these two views. You can intubate with those, but it's very challenging. So what about obstruction? This gentleman here has a very swollen tongue. He has angioedema. This can be from, classically, this is from an ACE inhibitor reaction. It's the same presentation you'd get with anaphylaxis. That tongue's in the way. How are we going to get a laryngoscope in there, or an OPA, or even take a look at the back of the airway? That's potentially occluding all those passages that we've just been talking about. The anatomy is distorted. Then, of course, here's a burn patient. He's got singed nasal hairs. He's got no eyebrows, no lashes. So most likely, if he was in a confined space, he probably had superheated gas, and there's a good chance that his soft tissues are now getting swollen, and they're growing as seconds tick by, and we're going to have to secure his airway as quick as possible. They're both going to have hoarse voices. They're going to be difficult to understand, maybe have difficulty controlling their secretions. So all this we can get from just from the doorway, looking very carefully and knowing what we're looking for to predict difficulty. Talked about neck mobility. This guy here, he's a prior burn patient. This is all scarred down. His scar has left him rigid. He can't flex his neck, not even if he wanted to. You couldn't do it if you wanted to. So what's that do to his airway? His anatomy, his alignment of those anatomic structures is going to be very challenging to intubate. This gentleman here, he's obviously had some sort of cervical spine fracture. The neurosurgeon put him in a halo for 6 to 8 weeks until the hardware binds into the bone adequately. Now, let's say he's got his Norco prescription, takes too much. Now he's a respiratory failure, doesn't respond to his Narcan. That's very difficult, right? You got to work around a cage. And then this patient is very similar to this patient, only he has senile kyphosis. So you could probably bend his neck, but you'd probably break it in doing it. So things that we have to be considerate about neck mobility. So we have to be able to predict who's going to desaturate. If you get nothing else from this talk, please remember this graph. I think this is very key, and I don't know that even a lot of physicians recognize this. When you have a patient, if you can get them to 100% oxygen saturation, if they're otherwise normal, they're a normal person, they happen to be involved in a trauma, but they have no other medical problems, they have good lung physiology, they've got a strong heart, if you can saturate them to 100% before they undergo rapid sequence intubation, these are minutes, these are saturations. You can see with a normal person, they're going to maintain their oxygen saturations. They're going to be absorbing oxygen. They're going to be extracting oxygen from the blood. And you can go all the way out to about 4 to 6 minutes before the curve starts going off. Now I want you to look what happens. Even if you're not healthy, here's 90%. What do all of these curves do? What do all these saturations do at 90% as time goes on? They just fall. They just fall off. And that's a healthy person out to 4 to 6 minutes. If you're an unhealthy person, if you're morbidly obese with CHF and maybe COPD to boot, you can be at 100% 1 minute, and a minute and a half be less than 60. That's the fall off. That's why we always talk about pre-oxygenate your patients. Let's follow the sets. If you're assisting a paramedic or a flight nurse intubating, be the hawk. Tell them if their saturations are dropping. Because what they're trained to do is when they get to 90 is abort. Or sometimes there's policies where they abort at 93 to give them a cushion. But they should abort the attempt if they get to 90%, because any time after that, it's all causing harm. We can abort, we can rebag, we can reoxygenate, we can start over and change something so that we're more successful on the second attempt or the third attempt. But as long as they don't desaturate, we've got time. But don't play in this dead zone here, because that's exactly what it is. So, tools of the trade. So, first responders, EMTs, they have oropharyngeal airways, nasopharyngeal airways, and it's not hard to understand how this works. We're keeping the soft tissues off the back of the throat, and we make a conduit to go to the supraglottic areas. I think more EMTs, EMT2s, are getting approved to use the King LMA, King LT. Same general principle, except we're occluding the esophagus now. We're making a seal between the soft tissue, anterior soft tissues and the posterior soft tissues, and ventilating through holes between the two bulbs so that air will easily pass into the trachea. Everybody familiar with a bougie? Anybody seen a bougie? Yeah. Okay, these are very common in the emergency department. You might see it on an air medical transport. It's called a gum elastic bougie. It's not as rigid as a wire stylet, but it's rigid enough to where you can actually thread it through the vocal cords. And it actually has a bend at the tip of it, so that as it goes through the cords, it's going to rub against the cricoid and tracheal rings so that you can feel that you're in the trachea. There's no bumps in the esophagus. If you intubate the goose, the esophagus, with a bougie, not only are you not going to get that rigid feedback, but it's not going to have any hang-up. You'll just keep feeding it like an NG tube, and it'll go all the way down. You'll lose the whole bougie if you let go of it. But if you're in the right place, even if you can't see it go through the cords, you're going to feel that tracheal ring feedback. And then as you keep pushing it, it's going to hang up as the airways taper, and it's just going to stop dead. And that's good confirmation. Makes you feel very confident that you're in the right place. And once that's in place, you can put this ET tube over the bougie, slide it through, because this is your placeholder, pull the bougie out, and you can ventilate. So a trick of the trade, it's very small, it's easily transportable. This should be, in my opinion, in everybody's backup toolbox. Okay? Of course, laryngoscopy and standard LMA. Who's here is familiar with the phrase, 2 is 1, 1 is none, right? If the battery's going to go out, it's going to go out when you most need it. If you don't have extra batteries with you, if you don't have access to them, take extra batteries. If you only carry ET tubes, carry something else. I don't care what it is, even an NPA, a King LT, but have a backup, because inevitably something will go wrong and you'll need something to do differently. If you can't intubate this patient, go to the LT. If you can't get the LT in, get the nasopharyngeal. Do something to achieve and maintain that airway. So once we get intubated, or while we're pre-oxygenating, we're assisting a patient, we use bag valve masks. We have to be cognizant of what's going to get in the way of a bag valve mask being effective. Obviously, beards, people that are edentulous, they wear their dentures. We need those dentures in while we're bagging so that the mask can seat on something and create a seal. Now, when we go to secure the airway, you might want to take those out because they can become foreign bodies, but while you're using the bag valve mask to assist ventilation, you need something for that to sit on. Those Mallampati scores, 4s and 5s, are going to be difficult to bag. And then remember that little girl with the micronaphia. Where's that bag going to sit on? I mean, there's just nothing to create a seal. So before we just become dogmatic and say, oh, we're going to bag first while we're getting ready, think about if that bagging is actually going to be effective. If you don't have a seat, you're just entraining 22% oxygen from the ambient air, and we're probably not going to ventilate much because half the bag is going to be going out of the desired pathway, right? So again, tricks of the trade. This is more historical. Here, this is a combi tube. Who here still uses combi tubes? Anybody? Couple? Okay. When I trained in the 90s, we used the EOA, which again is all the same principle. This was a blind tube here. This was designed to go into the esophagus, the esophageal obturator airway. This occluded the esophagus. There were some ports here, and you would bag through this, and it would aerate the supraglottic area. Again, just pay attention to the anatomy, the seat that you're trying to make. And remember, it has to be a seal between the front and the back, and circumferentially for this air to be sealed and go into the right direction. This is what an LMA or a King LT should look like from the top. This cuff should be sealed anterior, posterior, and to the sides. As you inflate the cuff, it should lift up just slightly. Give it a little tug, not too hard, but there should be a good seat to that, and you should maintain a good seal. So, if we're in a cardiac arrest, you have your choice. You have a crew that wants to intubate, you have a crew that has a endotracheal tube and say a King LT. You guys want to get out fast. Well, is it better to intubate them or secure their airway with another device, maybe the King LT? It's always been dogma that the best airway is an endotracheal tube. I think it's dogma because that's what we've done for so long. There have been studies out, several studies out, that show that in cardiac arrest, it's the odds of being successful in achieving and maintaining an adequate airway for transport is easier to place the LMA, especially with folks that don't intubate that often. It's easier to train people to insert the LMA, the LMA or the King LT, and we've shown that the ventilation is actually better than bag valve. So if you have a choice between bag valve and King LT because maybe you're not able to intubate for scope of practice or other reasons, maybe your battery went out, if you're going to choose between just bagging and using the LMA will ventilate better. Some people are concerned that if you choose to use the LMA instead of an endotracheal tube, well, what if they aspirate? There's not as much protection. Well, it turns out that's been disproven. It turns out that the aspiration events that prompted this concern, the aspiration likely happened before EMS got there. The one problem with an LMA or a King LT is that we have to maintain that seal, right? And the seal is generated by the cuff pressure. And the cuff pressure is about 15, maybe 20 centimeters of water. And if we have somebody that's difficult to ventilate, say that morbidly obese lady, we're fighting gravity and her weight to lift that chest. We may actually have to produce more pressure than that seal can hold, and therefore we'll lose the seal and we won't have an adequate airway. That may be a deciding factor in if you decide to use the supraglottic airway or if you're going to go ahead and insert an endotracheal tube. So think about it that way. What are going to be my barriers to success? So, again, what's going to make a supraglottic airway difficult to place? Obviously, we talked about the small mouth opening, obstructions, that stick through the throat, or angioedema in the gentleman on the slide with the protruding tongue, distorted pharynx, that guy that had the big bruise, maybe a fractured larynx. Anything that's going to affect the anatomy, those cuffs are designed for normal anatomy, not abnormal anatomy. And then we already talked about stiff lungs or a heavy chest. Let's make it difficult to ventilate. So, what are the indications to intubate? I realize some of you may not have the scope of practice to intubate, but recognize that you're probably going to be delivering the patient to a crew that does have the scope. And it's important for you guys to understand what the indications are. Maybe you've been with them for 10, 15 minutes already and you say, hey, they've got criteria, you got to intubate, here are the indications. You're going to make the handoff more efficient and thereby participating in better care. So if they haven't the ability to protect their airway, if they've lost their gag reflex, they can't manage their secretions like the angioedema patient or anaphylaxis, their airway is so distorted or injured that they can't talk. If you can't maintain oxygen saturations greater than 90% on your highest level of providing oxygen, if they have rapid shallow breathing or maybe even shallow slow breathing. If they're shallow and slow though, before you commit to securing their airway, think, is this narcotics and can I just rescue them with Narcan? Okay. Oftentimes we'll get people intubated. We'll get the history later on that maybe they had access to opiates. We give them the Narcan, they wake right up and we pull the tube out. So if they're slow and shallow, think, is it opiates? Maybe look at their pupils, are they constricted? So maybe we can avoid the whole airway issue and we can achieve and maintain an airway that way, chemically. What about any expected clinical decline? So that burn patient that had the singed nasal hairs, he was in a confined space and he's got a hoarse voice. We can reasonably predict that he's going to lose his airway in a very short period of time. He's the guy that we want to get to a facility or to a crew that can perform rapid sequence intubation so we can secure the airway before the glottis closes. Okay. So size matters when we're talking about selecting our tools. Just like we teach the EMTs to measure our nasopharyngeal airways and our oropharyngeal airways, we need to have the right laryngoscope blade size so that we can lift those soft tissues, get into the vallecula or trap the vallecula if you're using a Miller blade. We want to choose the right tool for the job. So, pre-oxygenation and apneic oxygenation. I just want to spend a few minutes talking about this. This is relatively new, but it's rapidly becoming a new standard of care, at least in emergency medicine, and we're trying to bring it into EMS because if it's relevant in the emergency department, it's definitely relevant for you all, right? So, if we have a high-flow non-rebreather mask, it's seated properly on the face, and we've got them at 15 liters per minute, we're giving them about 60% FiO2. 60% of the oxygen, of the air that they're bringing in is oxygen. If we can increase our regulator, some of you will have regulators that will give flow 50, 60 liters a minute. We can increase that inspired oxygen to 90%. That's going to increase our oxygen requirement. Okay. Now, we always think of the bag valve mask as a bigger gun, something more powerful to deliver oxygen, to oxygenate our patients. But what if they're semi-conscious? What if you can't make a perfect seal? You're just, quote unquote, assisting their ventilations. If there's not a seal, all you're doing is entraining 22% oxygen. And that 90% FiO2 that's in the bag is getting averaged with the entrained air from the ambient environment. So unless you can create a good seal, the ambu bag, just because it looks like a bigger gun, may not be delivering what you think it is. So how do we pre-oxygenate? Well, if this is somebody that we're semi-electively going to intubate, maybe they're in shock, or it's somebody that maybe they have airway compromise from the burn, if they can still take big, deep breaths, now obviously this isn't an asthma exacerbation or a CHF exacerbation, this is somebody that has good lungs, but their airway is compromised in some way. If you can put them on 60 liters per minute and have them take 3 minutes of just tidal breathing, tidal being what you're doing right now, or have them take 8 really big breaths, you will supersaturate their oxygen content in their blood, and it will extend that curve out. That curve, that desaturation curve I said, please remember, we'll extend that curve out so we can get extra time, so that when we go to intubate, we have a longer period of safety. So what about non-invasive? Can we pre-oxygenate somebody with non-invasive positive pressure? A lot of you have CPAP, yes? BiPAP? If you cannot pre-oxygenate them through liter flow, maybe they have de-recruited some of their lungs, they have fluid in their lungs from CHF, we can put them on non-invasive positive pressure, CPAP or BiPAP, whatever you have, and recruit that lung so they have more alveoli to oxygenate, to get more oxygen through to the bloodstream. But again, that takes time to set up, you need a good seal, so you have all of the potential problems that you do with a bag valve mask. Yes? Liter flow? So if you've optimally positioned them, the path of least resistance will be the airway. You're not going to get any more air in the stomach than you would otherwise by bag valve mask. Of course they'll get some, but it's the amount of pressure that you're providing when you get liter flow is about equivalent to a PEEP of 7. And when you do a bag valve mask, you're probably providing a PEEP of about 10 or more. So it's not as much as we're used to anyway, but it's a good question and a good thought. But if we optimize our airway, we've closed off the esophagus as much as possible. We've opened up the airway. So path of least resistance, it should go into the lungs passively. But good thought. Okay. So what's the best position? So obviously, head extension, neck flexion, just like we talked about. We want the head of the bed up at 25 degrees, and that goes into really the anatomy of the lower lungs. The way the blood flow goes, if we have our lungs up, we aerate the top of our lungs better, and that's where the blood flow is going, kind of in the middle of the chest. And that's exactly why we always lift patients head of the bed up on the gurney when people are short of breath. People breathe easier when you're at about 25 degrees, so no big surprise there. If they're a trauma patient, you have to use spinal mobilization. Obviously, we can do reverse trigger. So this is that curve again. I just reiterating the point that pre-oxygenated is designed to extend those curves out. These curves were created before the era of pre-oxygenation, so we can expect that we're going to push those curves out further. I can't tell you how much, but definitely better. Now, what about apneic oxygenation? This is a term that is new in the industry since this article at the top came out. This is by Rich Levitan and Scott Weingart. They're big airway gurus in the emergency medicine and critical care industry. And what they reminded us of is this. The hemoglobin in blood is designed to act as a magnet to oxygen, right? We have oxygen that freely diffuses through the alveoli into the pulmonary capillary membrane so that oxygen goes into the blood. If we can provide a high concentration of oxygen in the upper airways, as that oxygen freely diffuses across the alveoli, there's now going to be a sink. It's going to create a vacuum, and all that oxygen is going to fill that space. And if we pre-oxygenate, to give a head start, we keep oxygen going during the intubation attempt, meaning high flow nasal cannula. That nasal pharynx is full of 100% oxygen. We're going to fill it up, and we're going to get about 250 mLs per minute of oxygen going into the blood and increasing our oxygen content, further pushing that curve out. Now, what's 250 mLs per minute? Well, let's put that in perspective. We're used to giving people 15 liters per minute by mask. So that's big, right? It's a lot of oxygen that we can freely diffuse without the chest wall moving at all. This is all by vacuum effect. So how do we do that? Once we've pre-oxygenated, if you're assisting a crew that's providing rapid sequence intubation, you're going to pre-oxygenate just like we've been talking about. When they go to sedate and paralyze the patient, you're going to switch to a nasal cannula, just a regular old nasal cannula that we usually don't go above 6 or 8 on because it hurts the nose. We're going to crank that up to 10 or 15 liters per minute. Now, they're already sedated. They're not going to remember it. They're not going to feel it, so it's not uncomfortable. It's not going to hurt them. It would be very uncomfortable if they were awake. But during the whole time that the practitioner is going to intubate, they're lifting up the tongue, they're getting their view, they're lining up their shot. This person is getting 250 mLs of oxygen that they wouldn't have otherwise been getting if we didn't have oxygen flowing, refilling that sink that's being formed down in the alveolar level. Does that make sense? You guys now have heard data that I would say 80% of emergency physicians are just now learning. Let's see, so what about bag valve mask ventilation? All the bagging, if you need to bag, ideally should be done before the rapid sequence intubation, before the paralytic has been given. Okay? What we're going to do is we're going to paralyze all the muscle so that it's easier to lift the muscles of the throat to increase the chances that we can see the anatomy that we need to see. But we're also going to paralyze that lower esophageal sphincter that keeps all the gastric juices down there. And if we bag, if we fill it up with air, which is the issue that the young lady was talking about, we could actually cause them to aspirate during the event, and that's a problem. If for some reason we need to ventilate, we need to use the bag valve mask because they're desaturating faster than we anticipated, something else is going on, the reason to do that is to recruit more alveoli. Maybe they've got collapse because they've been on their back too long. We need to increase their oxygenation. If their saturations force you into the situation, you can do it, but we want to avoid doing it by setting ourselves up for success up front. So, ventilation. If we are using CO2 detection to make sure that we're ventilating adequately, if the CO2 is rising, we need to ventilate more. We want to blow off that CO2. And what are the situations where we might want to do that? Well, maybe someone in DKA or a burn patient that we know is going to have a metabolic acidosis. Any further acidosis from hypoventilation is going to be bad, so that may be somebody we want to bag. Somebody with a traumatic brain injury where they've increased intracranial pressure. Increasing CO2 is going to increase cerebral blood volume and increases the pressure in the brain. So that's why we bag. We used to talk about hyperventilating patients when they have brain injuries. That's why. oxygenation, just like I said. But remember, you're going to have to squeeze gently so that you don't open up that lower esophageal sphincter and cause an aspiration event. So before we, as a team, whether you're the one intubating or not, as a team, if you're delivering to a scene, a flight crew, we make the decision that we may need to intubate, we want to perform a rapid sequence intubation. This is the most dangerous thing for you and the patient that you're going to have to decide to do. When we decide to paralyze somebody, we're deciding to produce immediate, unconscious, unresponsiveness and paralysis. Once we do it, they're in our hands. We did something. And if we do that and we fail to intubate, it's called a clean kill. No one wants that on their conscience. No one wants it for their patients. So before we decide to do a rapid sequence intubation, as a team we discuss, ask yourselves 2 questions. Does this patient need to be intubated? Have we already achieved our goals? If they have an airway, if we're meeting minimal oxygen and ventilation requirements, do we even need to go further? We all can intubate, but should we? That's the question. And then have I done everything to optimize our chances for success? Ask yourselves those 2 questions before you proceed and take away someone's ability to breathe at all by paralyzing them. Indications, we talked about airway protection, respiratory failure, their work of breathing, they're failing because they've been breathing so hard for so long that they're starting to fail. Again, we talked about anticipated clinical decline, like the burn patient. We have patients that are in shock and their metabolism is so fast that they're consuming their oxygen faster than they can breathe and get it. And so we want to take away that metabolic demand by paralyzing them. Those are indications to intubate somebody. Sometimes I'll get calls from ground crews saying, you know, the PHI crew was taking too long. They were on the scene, they were futzing with this, they were doing that, they were looking at this list, they were looking at their plan. And just like the pilots on commercial airliners, they go through a checklist before they take off. They want to make sure that they don't forget anything, and they do it the same way every time. That's what makes them professional, and that's what makes them so safe. That's why it's so much safer to fly an airline than it is to drive a car. How many of you go through a checklist before you get in your car? Maybe at work you check out the ambulance, and you check the oil, you check the lights, you make sure all your sirens are working, you may check your supplies because they make you. But the reason we do that is so we don't forget things. And I don't expect you to memorize this. In fact, these are on cards, on the flight crew's badges. But just to be aware, we want to have a good plan. We want to prepare. We want to make sure we have our equipment. 2 is 1, 1 is none. We want to make sure we have redundancy in our batteries and our supplies. We want to protect the cervical spine. We want to make sure that we've really focused on our position. Have we pre-oxygenated? Have we given any pre-treatment that we need to? Are we going to paralyze? What are we going to use for induction? What's the right combination? What's the right cocktail? Are we going to be able to confirm that we're in the right place? If you have end-tidal CO2 detection, that's the gold standard. Once we intubate, we should check with end-tidal CO2. Post-intubation management, are we ventilating well enough? Are we getting oxygenation well enough? Cricoid pressure, Selleck's maneuver. So it used to be recommended, it is not. It is throughout the literature that's been studied over and over again. It causes more harm than good. It actually increases pressure. You can actually burp that lower esophageal sphincter and open up the esophagus and cause an aspiration event, which is silly because what was the one contraindication to Selleck's maneuver? Well, if they start to vomit, you're supposed to let them vomit. So we induce them vomiting and then we let go. So no longer recommended. All right. When we're preparing our equipment, we want to make sure we have adequate O2, make sure that we have all of our monitors, our masks, everything we might need, make sure that we have enough airway adjuncts, our backup airways. If we're going to intubate, make sure you have an LT. If you have an LT, make sure you have a nasopharyngeal airway to back up. Make sure you have a bougie. Whatever your backups are, have them out and ready so that if something doesn't go the way you want it to go, you can abort the situation, re-oxygenate, and reach for your backup. And it's already planned, just like Sully did when he was landing on that Hudson River. We're going to pick our RSI drugs and make sure we have all the equipment. So again, that's Bobby Fischer. He has this quote that I think is very relevant. I prepare myself well. I know what I can do before I go in. I'm always confident. because he has a plan. He's very systematic about what his approach is. If somebody moves one pawn one way, he knows already before what his next 3 moves are going to be. That should be us. If this airway doesn't go well, we know what our next 2 backup plans are going to be before we start. And that's where you should be. This is just an algorithm that anesthesiologists use to basically just kind of put into graphic form what the thought process, and the point is, the biggest square is all preparation. Preparation is key. So let's say the worst of the worst happens. Who here has protocols for some sort of cric procedure? Several, okay. So if we get to this, things are going badly, right? It increases our sphincter tone, we get concerned. I mean, how often do we do it? Maybe you practice it once or twice a year. I'd love it if you practice once a week, so it becomes second nature. But we're gonna go through a real quick review. And hopefully this will make it easier. It should not be as nerve-wracking as it is. And so hopefully I can reduce that just a little bit. Okay, so the anatomy, the top, just below the jaw, we have the hyoid bone, the laryngeal cartilage, and the cricoid ring. Between the laryngeal cartilage and the cricoid ring is the cricothyroid membrane, and that's what we're feeling for. And that's the hard part, right? You know, everybody doesn't have a perfect large Adam's apple like a big dude, but I'm going to show you a technique that works very well for all necks, whether it's a male, a female, large, small. I'm going to do the laryngeal handshake, okay? This makes it very, very simple. And ironically, we're going to learn this to save somebody's life, but it was actually created in World War II for our soldiers, how to take a life, right? So what they were trained to do was to take their dominant hand, grab just below the jawbone, and squeeze between their thumb and their fingers this hyoid, and crush the airway. That's what they were trying to do. So we're going to modify that just slightly, okay? So here's the hyoid. If you reach just below your jawbone, you feel the hard structure, that's your hyoid bone. If you just allow your fingers to slide down your neck, it's going to create a cone where it gets progressively more narrow. The next hard structure is going to be your laryngeal, your thyroid cartilage, okay? If you slide down just a little bit more, you're going to get to your cricoid cartilage. In between your thyroid cartilage and your cricoid cartilage is that soft, juicy spot. That's your target. That's your cricothyroid membrane, okay? That's the goal. Now, everybody says, oh my God, I'm going to stab somebody's neck and they're going to bleed to death. Well, it probably will bleed a little bit, but over here, that's your carotid artery and your internal jugular. It's way off to the side on both sides of your landmarks. Your landmarks are here. And somebody did a really good job in creating a structure that's designed for a cricothyrotomy. And the point is, here's your hyoid bone. You slide down, it tapers to the thyroid cartilage, and here's your cricoid cartilage. Here's the cricothyroid membrane. If you're midline and you're at that structure, you have a bony gate. You are protected. You're not going to hit the soft structures of the vessels here or here. You have a cage, and this cricoid ring is the only one that's solid, right? So you can go all the way back. You are protected. You're only going to save their life. So if you have a failed airway, you've done everything you can't oxygenate, you can't ventilate, find your structure and do the job and give them an airway. It's actually protected by design. So this is an example. So patient is right-handed. They're taking their dominant hand. They're finding the hyoid cartilage. They're tapering down. They find the soft cricothyroid membrane, and then they switch hands. You'll notice this was his dominant hand, right? Once you find that soft spot, you're going to take the index finger of your non-dominant hand to be a placeholder. You're going to put the knife or the needle, whatever device you're using for a cric, and you're going to plunge into that soft membrane. You're going to get a spray and aspiration of blood droplets, which is why you're wearing all your PPE and your eye protection, and you're going to have an airway. You're going to insert whatever device you have, whether you have a catheter or needle, wire, or a formal trach. Burn management, just quickly. So in the 20s, physicians noted that patients with large injuries would survive immediately, but then they would die days or weeks later. In the 30s, they from this developed a concept of thermal injury, which induced intravascular fluid shifts into the tissues. And at that point, if you had a 30% burn, it was associated with 100% mortality. But we've gotten better than that. We've developed this prognostic burn index. And if you take the surface area plus your age, back then in the 30s, if you had a PBI score of 90 to 100, you died. Nowadays, with all our technology and the way we treat in EMS and in burn centers, if you have a 90 to 100, 50 to 70, still severe, but much, much better. So what happens? In a nutshell, a burn causes an inflammation, it causes swelling, capillary leakage, the fluids from the intravascular cell space leak into the interstitium, the skin, the soft tissues of the throat, the larynx, and we have to replace that intravascular fluid so they don't go into shock. That's where we get our Parkland formulas and the volume resuscitation. This is in your handout. This is a list of patients that we should be sending directly to burn centers. I'm not going to read it to you, but suffice it to say that if these are present, if these circumstances are present, we should be calling base station to say, hey, can we get this patient to a burn center faster than going to, say, an access hospital that is going to have to transfer anyway. So, when you're evaluating a patient, if we're going to worry about their airway closing, the one question that you can ask that's going to differentiate whether or not you're worried about their airway and inhalation burn, ask this question. Were they in a closed space, like a small shed or a house, or were they in an open space, like they were barbecuing? If they're in an open space, the heat distribution into the open air is unlikely to go into the airway causing a problem. It's not impossible, but it's unlikely. If they're in a closed space, they have a hoarse voice, good chance they have superheated gases in their larynx. So this patient here, these are the arytenoids. It looks like an epiglottis, but these are the arytenoids. The epiglottis is way up here. These should be very bony and thin. These are normal arytenoids. That airway is about to close. That airway is closing. And that's soot on a larynx. So Bobby Fischer, he prepares, he knows what he's going to do ahead of time. So this goes to the plan as it pertains to burns. I like ketamine, it's fast, it provides an analgesia and sedation. Bottom line on fluids, if you have lactated ringers, please use those. They are more of a buffering solution than normal saline. We know these people are going to have a metabolic acidosis, and it's going to buffer that acidosis a little better. How much fluid? There are strategies, but it's unlikely that in the EMS environment you're going to give them too much fluid en route to the hospital. So get 2 large bore IVs and start the fluid going. Just a review, rule of 9s, 1st degree, 2nd degree, waxy 3rd degree, full thickness. And take homes, achieve and maintain an open airway, get positioned before you get them to submit. Pre-oxygenation and apneic oxygenation are new theories, but help, and you can actually start using it immediately. And we want to make sure that we can ventilate our patients. We want to prepare, we want to be systematic and be a professional. So I made these questions, but I haven't seen it. So review question number 1 for your CEs. Positioning is the first step in addressing an airway emergency. I'll give a caveat after the scene is safe. True. In an adult, we can achieve an optimal sniffing position by elevating the head until the ears are at the level of that's supposed to be external auditory, the sternal notch or the external auditory meatus to the top of the chest. Sorry about that.
I thought internal notch was very zen level.
Yeah, sternal notch, exactly. True. There are 3 components of an airway assessment. Remember lemons? Is it possible to increase the time before desaturation during an intubation attempt? Yes. oxygenation can occur even without chest movement. True or false? Questions?
We have time for one or maybe two questions. Go ahead. That good? All right, Rich, thank you so much.